So good afternoon, everyone. Welcome to the fourth of 5 implementation science seminars that we have planned for the school. I want to thank you for coming here and make sure that everybody knows that we have one more seminar series left in the year. Dr. Hendricks Brown will be joining us in May, so keep an eye out for information about that seminar series. At this point, I'd like to turn it over to Dean Clegg so he can introduce our guest speaker for the day. Dean Clegg?
Thanks, Jen. Well, first I want to congratulate you and David for just having exciting speakers come in. It's really a great program. And I saw David Peters yesterday, who is an author of this WHO report on implementation. We should get him to come and talk about that report. So it's my happy duty to introduce Alice Ammerman. And Alice, just to say that you're one of many distinguished speakers we've had here, and I've learned a great deal, and I know I'm going to learn a lot from your talk. So let me just tell the people a little bit about you. So Alice is professor at the Gillings School of Global Health, Global Public Health, and at UNC, an incredibly strong school. She's a professor of nutrition, and she's PI of a Center of Excellence for Training and Research Translation, thus why she's here. But she also directs a prevention research center there, the Center for Health Promotion and Disease Prevention, which is funded by the CDC. Her research really focuses on the design, testing, implementation, and dissemination of clinical and community-based nutrition and physical activity intervention approaches for chronic disease reduction, especially in low-income and minority populations. She has practice collaborations across the state and across the country. And the Center for Excellence in Training and Research Translation really looks and is charged with identifying translation and dissemination of evidence-based interventions on obesity and cardiovascular disease prevention and control. She's distinguished. I won't go into all the awards she's received, but just to tell you a little bit about her education. She is a true Tar Heel. She got her DrPH at UNC, and she got her MPH there as well, and undergraduate degree from Duke University. So I guess some people do go from Duke to UNC, and you're proof of that. Her background is in clinical nutrition. She's a registered dietitian and a nutritionist. So please join me in welcoming Professor Ammerman.
So being March Madness time, we always have to say something about basketball. So just to enrich that story a little bit, I played on the women's basketball team when I was at Duke. That was, actually I do usually put it on there, and that's usually the only thing people notice. But I have, and my husband and I both went to Duke, now we're both at UNC. We have 3 boys who are diehard Tar Heel fans. They're kind of proud of the fact that their mom played basketball in college, but not for the dark blue side. So they just say that I played for the ACC. That's how they get around it. All right, well, okay, right. And I was just chatting with someone. I just heard this first time in like 30 or 40 years that there's nobody left from North Carolina in the championship. That's kind of a bummer. So, well, it's been fun to see some former students here and colleagues from various walks of life. And this is the biggest screen I've ever seen. I probably have more slides than we can get through. I'll skip through some things that you may know a lot about already, and we'll just kind of, and I want this to be conversational at least to some extent, so if you have a question, stop me along the way. So I'm not going to talk a lot about fruits and vegetables, but that's kind of what I live and breathe, and they make for good pictures, so start with that. Okay, so I understand some people were attracted to the notion that we're going to talk about funding, so I thought I'd kind of dive right into some of the keys to success here, not just for funding, but just the D&I kind of work. One thing is to think creatively about study design and measures. It isn't your typical sort of randomized trial all the time. There's a lot of different ways to think about this. So don't get stuck on the RCT rut But also remember this when you're a reviewer. If you've been on study sections, you know, we are the reviewers. We're the ones we complain about all the time when we get back bad scores. So keep in mind that we need to not be sort of influenced by thinking the only way to go is randomized trials, and that's the only way to look credible when you're reviewing a grant. So a lot of times when you're writing a proposal, I think D&I is still enough on the cutting edge, bleeding edge, that you need to kind of educate people about it, remind people that you're doing D&I research. So that means you're not necessarily taking it all the way to the physiologic outcome, depending on the measure. If you do good D&I community-based work, which is really, I mean, aside from the research part of it, it's really a good way to understand your community partners and what's really going to make things work in a meaningful way, then the research will follow. I'm a big fan of thinking entrepreneurially. I understand you have some sort of center of social something or other ventures, or you know, I think that's a way that we can think about sustainability, and another way to think about funding. So look for those opportunities, and I think in all walks of life, have a sense of humor. I'll try to integrate a little bit of that here. Here's a little humor from Russ Glasgow, who's really a leader in a lot of these areas. If an intervention works, and this is supposed to be a forest up there, and nobody uses it, does it still have an impact? So if you think of that old saying and just kind of reflect on that, because I think we have a lot of interventions that work, but also a lot that aren't being very effectively used. So just quickly on this, I am currently serving on the study section for the DIRH, the Dissemination and Implementation Research in Health, the PAR. We're not going to go through all this text, but I think this here is kind of a nice synopsis in terms of this notion that we really need to get knowledge beyond the books and the journals and out into the community, and the fact that NIH is recognizing this enough, and many of the different institutes are a part of this PAR. So this is one opportunity to write grants for something that's intended to support this. The reality of this, though, is that we review more than just DI-RH proposals. Many other ones are sent our way. And we can't really either ding grants or I couldn't think of a good opposite to ding, maybe applaud, for being responsive to the RFA. That's not, we evaluate the science, not the match with the RFA. So just because you've been responsive to the RFA doesn't mean the reviewers are going to give you a lot of points for that. So again, you need to keep educating them. I would say even on our study section, we're all still learning, and some are not as comfortable with this notion of what sort of outcomes there are with D&I research. So again, reminding people we're talking about implementation, how we can get it out there, scale it up as effectively and efficiently as possible. And the outcomes tend to be reach, fidelity, quality, sustained use, not necessarily the kind of end of the logic model measures. We used to, I think, disparagingly talk about process measures, but in a lot of ways, those are an integral part of D&I research. So what about this evidence-based piece? Very important. I mean, you do want to be able to show something has evidence in order to then justify disseminating it. But I also sometimes talk about what I call the tyranny of the demands for evidence-based programs and interventions. And I'm just going to say a little bit about that. Assuming you can read this. The data don't predict a tsunami with absolute certainty, so I say we wait. So waiting until all the evidence is in. As you know, with some of the obesity review panels, we now talk about the best available evidence instead of the best possible evidence. So we're not waiting until all the data are in before we take some sort of action. Says then we're agreed that all the evidence isn't in, and that even if all the evidence were in, it still wouldn't be definitive. I think this is the way people see a lot of researchers, and many of you have probably seen this, the fact that parachutes have not been subjected to randomized controlled trials. Would you be willing to be in the control group of a randomized trial? I like this statement. Then you can see the spelling is British. We think that everyone might benefit if the most radical protagonist of evidence-based medicine organized and participated in a double-blind, randomized, placebo-controlled crossover trial of the parachute. So, tactful way to quiet them a bit. And Larry Green's name certainly comes up in all of these kinds of discussions and the work that he's done. Pre-seed, post-seed model is one of the things he's known for. And I think focusing on this, that he always states things pretty directly. Where did the field get the idea that evidence of an intervention's efficacy from carefully controlled trials could be generalized as the best practice for widely varied populations and settings? So the notion that just the idea that something works, we say, okay, it's been studied and it works, and but there are so many different contexts and variables there. Sometimes I look at this notion of evidence-based intervention methodology. If you think about how a lot of the studies were initially designed, they're really around pharmacological interventions. So you have a fairly narrow target population. You have a very focused intervention like a pill of some sort of medication. Intervention implementation is pretty simple, and often the health outcomes are pretty limited as well, although there may be side effects and that sort of thing. But then if you look at my world, a dietary intervention, you have widely varying populations and with different health statuses. The interventions can be many, many different things. We often talk about the kitchen sink approach, where we try to throw everything at it to have an impact, and then sorting that all out can be challenging. Implementation can be a wide variety of things. And then the outcomes are also, and these are kind of constantly changing as well. If you follow the science of dietary fat, there's a lot going on now in terms of moving more towards more high-quality fat, away from low-quality carbohydrates. So much more complicated when we get into the behavioral realm. And then just to slip back into March Madness for a minute. This is from quite a few years ago. This was Tyler Hansbrough, if anybody follows this closely. Actually, I made the mistake of showing these slides at Michigan State one time. Not remembering that was here. So, the saying with March Madness is that where any team can beat any other team on any given day, and sure enough, that tends to prove true. Kind of a different picture here in terms of what they look like. At this game where those pictures came from, I think UNC was the #1 seed, and Michigan State was the #9 seed, and I think they gave us a real run for the money. I think we eventually won, but it was not easy. And at that time, again, only if you really follow basketball closely, this was right after a game between UNC and Duke where one of the Duke players came down hard on Tyler Hansbrough's nose and broke it. So he was, not intentionally, of course, he was wearing protective face equipment for some of the time. I think Dean Smith actually got a couple of technicals called on him, which was highly unusual for him. There's always the question of referee bias. Are you playing on the home court? They always pan the crowd and show the players' parents. Does that make a difference? Nerves, adrenaline, all these things, this has nothing to do with whether you're seated #1 or 9, at least directly, but are all things that could be changed and make a big difference in terms of the context. So if we were to use this term behavioral intervention madness, where any given implementation team can achieve strong effect sizes or not in any given environment with any given intervention. So many things can change. If we have a collection of studies all showing some benefits, then we are more confident about it. But there are still many ways that the context can make a huge difference. And in the evidence reviews, trying to see what we are going to recommend, kind of like the March Madness things, these are the things that we generally do not really look at. The charisma level of the intervention implementers. Often we hire the best and the brightest to do the implementation, and then they ultimately have to be implemented by the staff that have 1,000 other responsibilities to take on. What about implementation support? Is there parking? Is there childcare? Cost of delivery? patient variation? Are there champions on site who will really push this forward or will put the brakes on? Clinic flow, wait times, natural and economic disasters that might get in the way. We had one study over a period of years working in eastern North Carolina where we were working with blue-collar work sites, mostly women. These were textile mills. Eventually, most of those mills closed down and moved overseas, and then after that happened, there was a huge hurricane that flooded a lot of the area. So, you know, that kind of messed up a lot of our careful planning in terms of the research. So this kind of traditional focus more on efficacy and internal validity doesn't really account for things, and you'll recognize some language here if you're familiar with the REAIM model, and I'll talk a little bit more about that later if people are not so familiar with that. This notion of, you know, are we really reaching the people intended, or are we preaching to the choir, which often happens, you know, people show up because they're already halfway there rather than those who are most in need of the intervention. Can the institutions adopt it long term, or is it dependent on just the structure of the research process? Can the staff currently in place implement it, and can it be sustained and maintained over time? So often we, I think, trade off external validity in favor of more internal validity. And it's really the external validity that determines the potential for translation and dissemination. We have to really think about these intersecting systems and context, looking at the socio-ecologic model, multi-level interventions, and then thinking about how decision makers come to play. And you've probably heard this quote from Larry Green: if we want more evidence-based practice, we need more practice-based evidence. We really need to generate evidence from the communities where things are being implemented. So speaking of the practitioners, if you talk to them about translating research, there's a number of gaps. One would be the accessibility gap. Do I, the practitioner, really have the kind of resources that the researcher brings to the table with a big NIH grant once that grant is gone to be able to continue it? Credibility, you know, is the situation really similar from what was tested for the evidence-based intervention to what is available to them long term? And then this kind of expectation, do we really have to do the highest level of intervention to have an impact? So some of the kind of unintended consequences of this EBI tyranny, thinking of researchers, and we've been talking about this in some of our smaller meetings this morning, there's a lot of pressure for our interventions to be efficacious. So that means in our proposals, we put highly intensive, costly interventions to try to prove that efficacy. And we say, well, we'll worry about effectiveness later. And things have been changing, I think, on review panels, but it used to be that people would argue, well, throw the book at it, do everything you can, then if that works, then we'll see if we can scale it back. But I think we are recognizing that there's only so far we can push that we really have to do more in the way of kind of designing for dissemination from the beginning. But then sometimes that's hard to get that funded because the reviewers will say, well, that's not going to be powerful enough to have an impact. And then if you are designing for dissemination, you might find it hard to publish papers that have just a modest effect because it may have more sustainability, but it's not going to have that big, impressive impact that we all want to see. It may not be included in evidence reviews if it doesn't kind of make that mark in terms of impact. May appear to be sort of a wimpy intervention. And then sort of ironically, because of all of these things, then it may fail to be included in terms of dissemination when it may actually be better designed for that. Just, you know, there's the attributable risk, the notion that if you reach a large enough number of people with a small impact that you're going to have overall a bigger impact than a very tight study that has a high impact with a small number of people but can't really be generalized. And in terms of practitioners, this notion of the evidence-based intervention tyranny, I think they're feeling increasingly removed from the research to practice process. Really kind of afraid to try anything new. You say, well, it has to be evidence-based. We can't, experiment with anything else. We can't do something we think will really work with our population because it hasn't been proven. That's one reason we try to include practice-based evidence in what we do, so something that's bubbled up from the ground, from the people who really know what they're doing, if we can then evaluate that rather than simply take something that we've designed and then try to put that on top of the environment. And I think people see some of these evidence reviews as a barrier rather than an aid to intervention selection and implementation. And I'll show you some of this. Dean mentioned the Center for Training and Research Translation, where we've tried to navigate this for people. So some of the kind of filter criteria for decisions that are important for dissemination and implementation: feasibility, sustainability, effects on equity, potential side effects, and then acceptability to stakeholders. So policy, a number of you have mentioned an interest in doing policy research, and this is not an easy thing to study. We can't write a grant and say, well, in New York City, we're going to change this policy, and then the control group's going to be San Francisco, where we're not going to have that policy. Policy happens, and we have to figure out a way to study that. Fortunately, more and more funders are coming up with rapid cycle turnaround for funding, so that if you see something that's about to be implemented, you can get a quicker turnaround on a proposal, so that you may have a better chance of getting some baseline information. So here's a little audience participation. If we want to test an intervention for diabetes, just read through this, and I'm interested in your thoughts about which is the better design. As soon as anybody has an opinion, just Mm-hmm.
Because it's going to be the one that has the greatest external validity and the one that has the potential to have an impact on many populations and on many different health outcomes that can probably be more easily taken up and acceptable
Mm-hmm.
to the real world people who potentially benefit from it.
But those of you who may be students who are taking research methods classes, would you have picked that based on what you've learned about study design? How do you control bias? Do you let everybody into the study to control for bias? How do you draw conclusions that are internally valid? Well, maybe you guys are all learning about D&I from the beginning, but Lisa is right. All right, the dean's orders. Anybody want to talk? Yes. Yeah.
Choice B is much more complex. There are many more variables.
Mm-hmm.
I'm concerned about sample size. Concerned about being able to compare subpopulations, not only at the health department level, but also at the patient level.
Mm-hmm. Mm-hmm.
And it seems to me like you have to rely more on econometric techniques to try and control potential confounders rather than having the purity of an RCT
Right.
to answer that question.
Could people hear that? So kind of having to rely more on statistical methods to control things because it's not as tightly set up. Yes, in the back. That's a good point. And what would you say to that? Other thoughts on that?
So I have a question with, so with choice B, you
Mm-hmm.
So why be left out in comparison with the current standard of care choice group?
Does anybody have a name for that kind of research? Comparative effectiveness research. That this is something that's being pushed now by NIH in an effort to get us closer to sorting out what we should be doing. But that is a real issue there. I think the assumption is that in this case, these are two models that have been already tested against control groups and found to be effective. And so now we don't need to do that anymore. We need to move on to the next step of comparing them to each other to see. Would anybody add to that or alter that? So comparative effectiveness research is a whole line now of funding that's coming out in terms of, but we've just completed one, and we were comparing for cardiovascular disease prevention. We were looking at a individual counseling versus web-based, and we found that both had some impressive changes, and they were cost effective, the web-based a little bit more, but we don't have a control group, and we are a little worried about getting that published. But we were responding to an RFA about comparative effectiveness research. So, yeah. Any other thoughts on that? Yes. Mm-hmm. Mm-hmm. Do you want to say anything? I don't have a lot of detail on study design, but that's, I guess, the main point I was trying to make is to warn people that not to be limited by randomized controlled trials, but to also recognize what the limitations are if you don't have that control group. But if you're not taking it all the way to the kind of endpoint of physiological outcomes, then to understand the processes and the mechanisms, those can be looked at with different study designs. And this is kind of a reason for the concern about all of this is that, and really what's pushed us more towards these comparative effectiveness research and other models is that the decision makers often don't feel like if they really have what they need to make the decision. They want to know, what's the most cost-effective way to go about this. They don't really care so much whether it's better than nothing. They want to say, okay, I have these different options, so what should I put my money on? What should insurers choose to cover? So you've probably heard these kind of grim numbers that I think fueled the whole notion of the Clinical Translation Science Awards from NIH, is that we're really not doing well in terms of scaling up and out, and that it takes anywhere from 14 to 17 years for kind of proven ideas to actually make it into practice and to get to a point where it's actually impacting human health. And this concern we've been talking about, that research-tested interventions don't always translate into practice. And then there's the notion of, well, if it works and then you build it and offer it, then how are you going to get people to come, and what are the circumstances that will support that? So again, on the policy challenge, what we're looking at now is comparing the relative benefits of two different approaches, and then considering the cost and implementation. Now, another more recent funding mechanism is for PCORI funding, patient-centered outcomes research, and that's kind of an interesting model. It's kind of aside from NIH, and it came out of some of the Affordable Care Act discussions, and interestingly, it's very similar to a lot of the community-based participatory research. Kind of there's a big emphasis on engaging stakeholders with that. However, they will not allow you to include cost effectiveness in that, which seems like an obvious sort of thing. Apparently, it goes back to these concerns about denying care, the old thing about the death squads that Sarah Palin talked about, with this notion that you would somehow deny care to anyone and based on the cost. Yeah. It does have to have a clinical anchor, but you can push that beyond that to include interfaces with public health as long as there's a clinical component to that. That's a good point. I served on one of their obesity working groups, which was interesting. They brought in people from Weight Watchers and all these groups that are more the kind of lay arms of obesity interventions, and that I specifically asked them about that because I said I don't do clinical obesity work, and they said, well, we're open to other things as long as it ties back eventually to a clinical. Has anybody had success with a PCORI grant that would want to share that? Or yeah. You're going to have to speak up. Mm-hmm. Okay. Mm-hmm. I saw someone kind of put some numbers up the other day of how many hours they spend with their doctor and how many hours they spend in the rest of life. When you think of it that way, it's kind of striking. If you haven't figured it out, Lisa and I are PIs on a similar funding mechanism for the CPHHD, Centers for Population Health and Health Disparities. So we wrestle with these issues a lot. I think I've covered that part. So what do decision makers care about that researchers usually don't? So this credit to Ross Brownson, who's put together these kind of clash of cultures, as he calls it. And so you've got the political decision making here. They have to make big decisions about assigning resources. They look for the problem. They make a political judgment. What's going to fly with people? What's the culture? What are the sensitivities? They have to build support for that, produce a new initiative. Data isn't always a big part of all of this. Whereas on this side, we've got the usual sort of data cycle. We have the problem, hypothesis, study, and then somehow these all need to kind of inform each other. And so we really need to know more about what the policymakers need to know. We could collect more data about some of these things, but we don't usually integrate that into the work that we do, but we might have more of an impact if we knew what they needed in order to convince their constituents and others to move that forward. So a lot of work that could be done there to affect policy. So in terms of the policy-related challenges and opportunities, the big challenges we're just talking about is this gap between policymakers and program planners and practitioners. And we have to really think how that impacts our peer review, editorial tendencies. And then opportunities are to use more of this PCORI or CBPR kind of principle to really work more closely with policymakers. How many of you engage policymakers in thinking about your research efforts? Good. So that's I think you are among the rare folks that do that, but certainly could move us forward. And then thinking more about sort of multi-level methods that look at all levels of policy all the way down to the individual level change. So thinking of funding, certainly writing grants is one way to do it. It's getting harder and harder these days, as we're all experiencing. So I also like to put in a plug for entrepreneurial thinking. When I first started talking about this maybe 8 or 10 years ago, my colleagues who know that I'm kind of more to the left side of the political spectrum said, Alice, have you sold out? Because they just thought that anything entrepreneurial had to be greedy capitalism. But there's a whole kind of lexicon now around social ventures, social entrepreneurship, and really a lot going on in terms of what we can do here. This actually, I teach a course in public health entrepreneurship, and I hadn't come across this until this year. They call it the lean canvas for business model planning, and the irony of all of this is that it's really a CBPR kind of method. A lot of the business model planning has you, coming up with your great idea, coming up with a business plan, and then going out and trying to see if it'll work. This is coming up with a general idea, and then you try to work from a kind of context like this, spend a lot of time with your customers, various segments, and figure out whether they even want your product and what some of the barriers are going to be, and then make a lot of revisions early in the process with the greater chance then of ultimately being successful with that. So quick aside here, a little story from yesterday that had a little entrepreneurial edge to it. I flew Southwest around midday to get up here. Share the spirit, have to share your seats. And they told us that they weren't going to be full, so I kind of went to the back, and I have long legs, so I was hoping that I would not have to share with 2 other people in the 3 seats. So I went to the back, looked like nobody was going to join me, so I pulled out my grants, and I happened to be reviewing grants for our CTSA, which happened to be focused on dissemination and implementation. And this one, not really my area of work, but we all have to stretch a little bit when we're on review sections. So this was preventing drug overdoses, the use of naloxone. How do I say it? Naloxone, okay, which is a rescue medication for opioid overdoses. And North Carolina is experiencing a huge problem with this. I think this is broader than North Carolina as well. Actually, the Senate has passed Bill 20 to use naloxone to allow much easier access through drugstores. And so this proposal is formative work to develop persuasive messages to inform a campaign of how to get people to really use this more effectively. So just before they closed the doors, somebody did come to sit next to me, and it turned out to be Elvis Presley. He gave me his business card. He calls himself an Elvis tribute artist. He was not decked out quite as much of this, but pretty close, and it was really obvious what his job was. I kind of didn't know what to expect, so I kind of buried my head in my grants a little bit more, and I didn't say much until near the end of the flight, and then he started chatting me up a lot, invited me to go on stage with him at some point. And he looked over at my pile of grants, and I was still looking at this one, and he goes, "Are you a teacher?" And started going on. And then it just sort of occurred to me this kind of irony of the situation, as his demise was related to opiates, although if you look it up, there's all kinds of debate about whether it was really constipation and bowel problems related to the opiates. But so I thought, well, this would be a great message campaign if you had a picture of Elvis saying, we only have, or if you're a believer that the king is still here, you might say, good thing. So he's still alive somewhere because of that. Anyway, so that's creative thinking in terms of how to go about this. So I mentioned I teach this public health entrepreneurship class, and just sort of through networking, we identified this ED doc at UNC who came to our class on Monday night. So this is all very fresh. And he assesses patient experience with health outcomes. Now, there's a standard approach to this that's used in all the hospitals, but apparently people just kind of use it to check it off the list that they're measuring it, and they don't really use it for much of anything. And so he's really developed this idea. He's kind of a reluctant entrepreneur, I would say, as a kind of comparison. This is what the website says in terms of this solution that they're using, where they give very quick real-time data back to providers who then have made quite a few changes in their practices. They have much higher response rate from patients because they feel like they're really having an impact. So this is just a little UNC PR about this. But this is the guy, Seth, very sort of mild-mannered guy, and I invited him along with what we call a serial entrepreneur. He's actually very much in the social venture area, but he's started many businesses very successful in this world. And so he sort of interviewed Seth about this. And he really, his mission is to create a better way of understanding the patient experience and to make, to improve the process. Apparently they worked with the dermatology department. I think there was a quote from them the chair of dermatology, obviously very satisfied. And they address things in the waiting room, how the physicians answer questions, how the parking works. Seth says he hates the name. I think it came up from some thing of these kind of nerdy academics who put together a name, and now it has no real meaning to the rest of the world, but they're kind of stuck with it now. Biggest challenges, hiring the right people. This guy who's working with them helped them just determine that they really had hired all the wrong people to do the management kinds of jobs, which is really important to figure out if you're going to be a successful business. And he asked him, what do you think you should charge for it? And he said, well, there's no copying or postage, and hospitals are really strapped. So I actually argued for lower price. But then that might actually make it more successful in actually doing what he wants it to do. So this is just to kind of get you thinking about the fact that there could be a lot of different approaches. So I am going to race through this. This is one of my students and I are working on this idea. It's kind of a behavioral economics approach, if you're familiar with that idea, to try to get kids to improve their high school lunch choices. And the challenge here is that there's short lunch periods, long lines. The periods are set up. Everybody eats at one time so they can get their work done, extracurriculars, and of course healthy is not a priority. And for the school food service perspective, there's a lot of pressure now to increase the healthfulness of the food. And actually new federal guidelines are really making a big difference in terms of what they're selling, but they're finding that the kids are not all rallying to this healthier menu. And they have fewer customers at high school. Now, if you know anything about the economics of school lunch, they have to have kids participating, either free and reduced when they get government reimbursement or the direct pay. So the question is whether it's possible to get students to buy healthy school lunch options and make it more convenient for them to participate. So we've developed with a software company this, what we call taste texting, so they can text in their lunch order. Behavioral economics says if you pre-order things before you're smelling the French fries, that you have a better chance of making a healthier choice. We only offer healthy options on the menu. We don't tell them that because that would be sort of the kiss of death to say, here's your healthy choices. But they get the fun part of ordering it and the convenience, and they get to specify what time they want to pick it up, which makes it appealing to them. So it's this combined system of text and web ordering using behavioral economics. It sort of gives them this implicit choice in that we only make the healthy things available because of the convenience. That's what really matters to them. Have any of you seen the video, the piano staircase thing? If you Google that, you would find it. So it's another behavioral economics way of getting somewhere, I think in the Netherlands maybe, where they had a staircase coming out of the subway and next to an escalator. And everybody, of course, took the escalator. But they turned the staircase into a piano that actually played music. Of course, very expensive. But then they found everybody was shifting over there because it was a lot more fun. And the same company did something that I think was actually more creative, where they took trash cans and outfitted them with electric eyes so that when you threw something into it, it set off a sound where it would go shh. So it sounded like it went down, a long way and then kind of exploded. And so they showed a hidden video camera of kids running all over the park, picking up trash and throwing it away so they could hear the sound. So this notion of behavioral economics, of getting people to change things for reasons that aren't necessarily what you're trying to accomplish, but they still get them there. So we've just done a little pilot study here, found that technology works. And the people, in terms of making decisions to use it, they're looking at good taste, time in line, and found it pretty easy to use. I'm going to skip through this. So this is just kind of an example of sort of an implementation strategy where we're satisfying the needs of both the schools to get more participation and the kids to get healthier lunches. So re-aim, I have some slides on that. How many of you work with that regularly or familiar with that? Okay, not too many. So I'll spend a little time. Russ Glasgow is really the brainchild behind this. This is really, I would say, if you're writing a grant on D&I, it's not a bad idea to include re-aim because it's a way of structuring measurement for dissemination and implementation research. And this is just some of the philosophy behind that. Again, recognizing that RCTs are often too slow to get things into practice. So this is his joke on bench to bookshelf instead of bench to bedside. And kind of a neat model of traditional RCT that kind of funnels everything into a narrow subset as opposed to a practical clinical trial, which is randomized trial, but it's designed in a way to be more inclusive and a broader sort of studies. And here you have a broader eligible population, not as many exclusions, and you have a broader subset where you can claim effectiveness, although, as we said earlier, it's kind of like that A and B comparison. It's messier and harder to make some claims from it. I think we've talked a fair amount about external validity. Russ and Larry Green and others actually had a whole campaign writing to journal editors to try to get them to pay more attention to external validity in studies so that all the judgments based on what was published were not based on internal validity. A number of people have signed off on that idea. You've probably seen this Einstein quote. Again, sort of trading off more external for a sole focus on internal validity. So this, I can certainly leave my slides with people and you can look at that. This is just kind of making the point that you can use REAIM in both the planning and design phase, actually also the evaluation part, and then in terms of the publication phase of how you write things up and really share more valuable information for people who are trying to move to a dissemination and implementation stage of things. So summary, it's really, it can be used for both planning and evaluation and write-up, as you just saw. Each of the domains can be intervened on. You can improve reach, you can improve adoption. That's a lot of what implementation research is about, is trying to improve the adoption or the implementation by the staff. And then certainly the maintenance piece is what we often tend to do a poor job on. So it can be used in all these different ways. We should be stopping in just a minute. We have some goals on evaluating policy. Some of this is aimed at practitioners, because if you're really going to evaluate policy at the local level, you have to get them to participate as well. Let me just show you a little bit about what this Center TRT is. This is the website. I think if you just Google Center TRT UNC, you can find it pretty easily. So what we do is, and I was talking to someone about Debbie, which is kind of something parallel in the HIV area, and we designed some of this based on that. So we look at all levels, all three levels of practice, research, tested, and emerging. And we also look at strategies, so not just a discrete intervention, but approaches that have been shown as a general sort of approach to be effective. And so this gives people in the local level more opportunity to tailor things using strategies that might fit better at their situation. And these are some of the types of strategies, like active transportation, so facilitating the built environment around bikeability and walkability, changing access and availability to favor healthy foods and beverages, campaigns, community-wide campaigns for both healthy eating and physical activity. So we evaluate interventions for their effectiveness and then get this evidence out there for broader use, and then make available to the practitioner all the things they would need to be able to implement it. So that's what makes it easier to the intervener. So these are things you can look at on the website. I'm just going to skip through those. Again, things that you might evaluate when it comes to the intervention framework. And we've got a whole section on evaluating policy and environmental change with some logic models and other things that can be applied. We've we're developing those for each of the interventions, but there's also a general guide for those of you who are trying to work in the policy area. And webinars, and then there's actually, if you really want to learn about REAIM, there's a module, a training module on that specifically. And here's, I don't know that you can really see it, but here's the web address again. It's very easy to Google. Okay, so I usually try to end on a note of humor. So I talk a lot about obesity and food systems. So creative marketing strategies are always key. And I take this from my elderly aunt who actually lived with us for almost 10 years, had an amazing birth date of 11/12/13. She made it to 99. And one day she was puttering around the kitchen and she said, "Alice, I didn't know they had low-calorie honey." And I was kind of surprised because I don't use usually artificial sweeteners, and nor did I know honey had them. So I looked on the jar and it said North Carolina local honey, and she read the local as low-cal. So if we can convince everybody, this is our secret to dissemination, is that all local food is low-cal. We might have something. All right. I'm sorry to race through much of that. I can certainly leave the slides. Any comments or questions? Yes.
So it seems to me that sometimes there is a tension between internal validity and external validity. Epidemiologists like to have all the variables controlled, they like to use very specific entry criteria and very measurable outcome. So you have internal validity, whereas when you go into, say, CER, you're looking much more external validity. How much evidence, how much of the internal validity rich studies do you have to have done before you take an intervention and apply it in this kind of research?
Well, I don't know that there's a magic answer to that. I think you mostly just have to sell it well. Now, some of that is going to relate, though, back to the external validity. If you say, well, this has, great impact, but we had, 24-hour chefs working with people, then that's not going to carry as much weight as something that was a little closer to what you're hoping to disseminate. So, I think some data that are convincing at the outcome level that people are generally looking for. Again, like with obesity, showing change in BMI can be very difficult with any sort of isolated intervention. So if you can make the case that we have lots of data showing that increased physical activity is associated with weight control, then if you show a strong impact on physical activity, then you can make a strong argument there. Shannon, did you?
Study designs that you presented. And could you give us some insight into example B? If your study section was reviewing example B, what kinds of elements of a proposal would you be looking for in making the case as to why that would be a proposal to fund?
So for the D&I wonder if I can get back to that quickly.
Key aspects to include in proposals that would appeal to reviewers.
Is this it? Yes. Okay. Well, one is to be able, like in the first one, is to have some breadth in the settings. I mean, you have to kind of limit, you can't do every possible mixture of settings, but to not just have, all in the same county or all, if you can show in multiple geographic locations and kind of rural, urban, again, it's always going to be a trade-off of how far can you push it, but to show that it's not just in this very highly selected group that you've done it. I think we talked about whether it's more of the CER kind of thing. I think this is a big one, this third bullet of who's eligible. We have a real tendency to exclude everybody who could complicate things. And the world of public health and clinical care is people with, and this is becoming actually a big area of funding and research, is comorbid conditions and multiple chronic diseases. And that is going to be messier, and it's probably going to lessen your ability to show an impact in one particular area. But that's the reality of what the patient mix is going to be like. So I think that one would be important too. I think the point with the last one is just that you measure things beyond the sort of usual suspects to try to understand how it might affect. Like I was talking with folks earlier in the mental health area, the notion of stress and other things that could have an impact that we often don't measure. Of course, then you have the trade-off of respondent burden measures and that kind of thing. Yeah. Mm-hmm. Yeah. Mm-hmm. Yeah, it took me a long time to understand why that was. Well, what you can do is say this is intended to be a dissemination and implementation research project, and that now I guess that's good and bad. Then that means then that you're eligible to be held accountable to that because you're stating that. But just because you walk through all the steps and comply very closely to what the RFA suggests, it's still going to be judged very much on the science. And that's where it gets tricky if the reviewers aren't buying into the science being somewhat different from the usual sort of outcomes research approach. So that's where I would just keep reminding it. And you could even quote from the RFA and say, this specifies that the outcome should be more at the level of implementation than at the efficacy kind of outcome. That's how you could kind of use the RFA, I guess, to support that. Does that help? Okay. Yeah.
The prevention research center portfolio has been quite successful in identifying interventions that have either had previously established efficacy through NIH trials and then been disseminated, or have used CDPR to build that intervention that's more geared towards dissemination. But it seems to me that there seems to be a real mismatch between really innovative programs being created within the PRCs and very little infrastructure support for scaling them up. In terms of your experience, who should be putting money into scaling up those interventions? Is it the CDC? Is it NIH-CDC partnerships? Is it business?
That's a good question. Actually, I think that does bring up a good point that we shouldn't necessarily just rely on the federal funders for this. If we really want to have an impact foundations, other funders that really tend to look less at the nitty-gritty of the science and more at the social impact, that would be a real opportunity to have an impact to fund the things that we can't get research funding for. But then to include enough evaluation to be able to satisfy the funder that, and sometimes that's at a different level of, there are a variety of ways that you can measure along the continuum of impact. How many, again, we have to give up this notion that process measures are not useful. That term, I think, is kind of restrictive. It can be reach, it can be participation levels, a lot of things that are associated with impact.
I also think that in the choice being in writing an application, that if you look at the clinic participants who's eligible in the outcome measures, you really can make an argument to say that B is actually inclusive of A. So you're actually reaching for a little bit more. You can find a lot of that in your data analysis. And you can really address it in the data analysis. We will look at these subgroups and we will examine. And so really, if all clinic participants are eligible, you can look at those
At the
who have no
subsets.
comorbid conditions versus those that do. So there's really variability. You may need a larger sample size, but that's very doable. And I think you can just say that you can argue that you will look at these things. It's not going to cost a lot more to look at many of those outcome measures
That's a good point. Yeah. Yeah.
Alice, thanks for great talk. And I wanted to ask, on the study section, sort of how much is there a shared definition of what is implementation research or implementation science? And a couple of years ago here, we surveyed the faculty, and Marty faculty said they felt they were doing it, and we asked what their definition was, and we received 60 definitions from 40 people.
Right.
How cohesive is the study section around sort of what the nature of the enterprise is?
It's not always cohesive. I mean, I've been a little disappointed in that when they've done trainings with us, it's been more like use the full spectrum of numbers and, you know, those kinds of standard things that you're always told for the study section, and not as much on what D&I research should be about. And there are times when I've sort of cringed and tried to, you know, you have to really go to battle in study section sometimes for something that you think is good. And there are times when I have to really try to make that argument that this is really what we're looking for, but it doesn't always fly. Yes. Thank you.